And thanks for giving me the opportunity to speak about not diagnostic EUS, and I can tell that it was just to make a little bit of debate because I do EUS for almost all staging and also for re-staging, because the only way to improve is to learn, and the only way to learn is to do. So that's, I will encourage you to do preoperative staging, but also staging after treatment, because the only way to really improve the management of our patient is just to learn. And unfortunately, many times we need to learn even with the patients. But let's get into points. The topic that Peter provides me is about another world of EUS-guided therapy. Okay, so it's about treating tumors or treating something different that is not only draining. And this came because the endoscopic ultrasound, as you know, is continuously evolving. So there is a continuous actualization, and there's always technological innovations. And if I make a question to all of you, would you prefer to have one of these mobiles, or do you want to prefer to have your smartphone or to your Apple Watch? I think we all have a smartphone. I do not have an Apple Watch, but I'm sure a lot of you have an Apple Watch. So that's something similar to what's going on in the US. Why not stopping in the past and not evolving with the future with all of the new technologies that we have, not only in imaging, but also in the new devices? And to give you an example, EUS started when the Oscar went to out of Africa, and this was like Tom Cruise looked like when EUS started. And this is after a lot of Botox, how Tom Cruise is looking now in 2018. So there's going to be a big change, and the change of Tom Cruise is somehow the change that we face when we're speaking about endoscopic ultrasound. And let me just have a small word about what is the meaning of EUS-guided treatment, EUS-guided therapy. Because for many years, and this is the graphic, it seems that the only role for EUS therapy is draining procedures. So we start to drain pancreatic fluid coagulation, cirrhosis, pancreatic necrosis, then we started to drain the biliary ducts, then we start to drain the pancreatic ducts, we start to drain rectal abscesses, mediastinal abscesses. Is everything a matter of draining? But come on, we are facing and we are speaking all the days about staging, about tumors, and we have a very nice tool that if we are able to stick a needle inside of the tumor, why cannot we do something else with these tumors? Why don't we change? But what about EUS-guided real therapy? And when speaking about real therapy, it's really treating diseases, treating tumors. So what is going to be my topic about is the change in your mind. So EUS-guided therapy is not only draining, but it's also treating lesions. So that's what I'm going to try to convince you and what is going to be the future. And you will understand why I'm speaking about the future, because we are still very, very in the beginning of the present. So this is, I think, is going to be a bright future for the next years. So, okay, I think I'm trying to convince about the concept of therapy, but what can we really treat? What are the potential indications for EUS-guided treating by this FNI, fine needle injection, RFA, and so on? So this is the first question that we need to put in mind, and I just want to share with you the data that we have, they consider that is a little bit accepted, or at least tested options for EUS-guided therapy of different diseases. So I think we know a lot about the pain in treating pain, EUS-guided, and we have Anand, who is probably one of the biggest experts and with most experience in what we're going to speak a little bit about EUS-guided treatment of pain, mainly pancreatic cancer. We can discuss afterwards about if there is a role in chronic pancreatitis or not. But also there is a role in treating pancreatic lesions, and we start to have some data on the role of EUS-guided therapy for cystic pancreatic lesions. We start to have some nice data on pancreatic adenocarcinoma, in pancreatic neuroendocrine tumors, and this is a lot of cases that we all have in our units. But we still, again, have some data on the treatment of gastrointestinal lesions, and I have included here, and I will show you some images on the treating of varices. But why not thinking on treating something about lung cancer? What about esophageal cancer? So I think the future is bright. We can access very different stations, very different positions, and we start to have some therapies that we can take there EUS-guided. So just keep in mind that probably these leads will really increase in the future. I hope it's going to be increased in the future. But for doing EUS-guided therapy, we know that the world in draining has changed with the development of the new systems like the Horaxios and the Expaxus and the Energy stents. It's really have made a change, and we're still willing that the companies are going to provide us with different options to even improve the therapeutic success when we speak about EUS-guided drainage, but what if we speak about EUS-guided therapies? What do the tools that we really have available today? And I can tell you that in the very beginning, if we just speak like 10 years ago, we almost have nothing. We just have the needle, and we just try to use the needles to inject whatever someone gives to us, mainly the biological oncologist and so on. But now we start to have specific and dedicated devices that we can use pure EUS-guided. And we're speaking about the fiducial marker placement. So we have now in the field fiducial needles. This is an example of the Cook needle, but this is also the fiducials needle from Medtronic. And now we know that Boston is also going to provide fiducials to be that can be used through the 19-gauge needle. So there is now the companies that start to provide. So it's not only those hand-made fiducials of the past, but now we have dedicated devices for marking lesions. Of course, we can work with EUS-guided retinal ablation or injection of anti-tumor agents, and this is quite easy because we already have the needles, but the premise is to find the proper substances that we can provide to try to treat these lesions. Now we start to have the RFA needles, and just to let you know that there's also some needles for EUS-guided photodynamic therapy. There's not so many data. I think it's only a couple of protocols, a couple of very pilot studies. And also there is something to starting about EUS-guided laser therapy, and this I brought in this example, what is, for instance, the cryotherm, which is some kind of type of radiofrequency. Instead of heating, it's just cooling, but it's a way of mechanical treatment that is being tested, and I will show you some data. So yes, we start to have some nice tools that can help us in treating different kind of lesions that we've already commented about. So if we want to start to know what we've learned over the last years and what we have in the literature, and let me start with what is not really a treatment, because at the end, the role of placing fiducials is just to guide the treatment of our radiotherapeutic colleagues. But we know this is a very useful technique. There is a lot of papers published in the literature. There's a very nice review that was published in 2016. And you see there is a lot of number of cases using different type of fiducials. So it seems to be a quite nice technique with not so many complications. And this is a discussion that you need to make with your radiotherapeutic agents. You need to discuss with them whether this is really needed or not. And I can tell you that with the development of the latest systems to guide radiotherapy, sometimes the fiducials are not as much needed as we thought in the past. So again, you need to discuss with your radiotherapeutic agents what are the systems that you have available in the hospitals, and according to this combined, I mean, we're living in the world of multidisciplinary teams, and this is again a part of the multidisciplinary team, so you need to discuss, and whether this is needed or not, please, you can really do it, because it can be a very nice tool to guide radiotherapy and to try to skip adverse events of a very aggressive treatment. And if we go to one of the latest and with the highest number of patients included, this is a study published by the HAM. Look, more than 500 patients that underwent fiducial placement. Look at all the different indications for the location of esophageal tumors, GI junction tumors, pancreatic cancer, rectal cancer, or some others. There is not so many adverse events. I think it's quite affordable to have 1.8 when you're trying to optimize the treatment and to avoid the adverse events of the treatment itself. And I think it can be a nice option in very well-established indications. But again, discuss with your radiotherapeutics what are the real indications and when you're really going to make a difference. As we just said in the previous talk, it's very important to know what we expect just to go ahead by doing any kind of therapeutic procedure. But probably the real beginning of EUS-guided therapy was with the treatment pain in pancreatic cancer, mainly by the select plexus neurolysis. And this is a very well-established technique. There is a lot of data published in the literature about the role of neurolysis for the treatment of pain, and we know that it's been tried to perform either bilateral, central, with different amounts of alcohol, but at the end, the good message is there is a quite nice technique with a very nice percentage of patients that are going to decrease the needs of opioids when you are facing pain in pancreatic cancer. We can discuss afterwards whether there is a role for blockading chronic pancreatitis. I am not a big believer, although we can discuss with Anand. He has some very nice experience in chronic pancreatitis patients. We have just tried, it's not so good, but I can tell you that in pancreatic cancer, and if you look at all of the data, there's a lot of studies in the literature with a very, very nice number of patients. It's really a very nice technique to try to improve pain and quality of life and outcome in patients with advanced pancreatic cancer. And this is probably the beginning of what we call EUS-guided fine needle injection, EUS-guided therapy, what we call the EUS-guided select plexus neurolysis. So once we start to understand how to perform this kind of therapeutic procedures, then why don't we go a little bit further on? Why don't only just not stop in treating pain? Why don't we go a little bit further on? So that's when we started, okay, what are one lesions that sometimes we have a lot of doubt how to treat? Sometimes we found this kind of lesions in very old patients with a lot of comorbidities, so we are not very suitable for surgery. And this is the cystic pancreatic lesions. And believe me, if for those of you that are starting to do EUS, this is going to be one of the biggest indications that you're going to have. Just remember that the data that come from the Netherlands speak about the 3% of the population, not of our patients, but of the population, had a cystic pancreatic lesions. So we are really diagnosing cystic pancreatic lesions almost in all of the EUSs that we're performing in the hospital every day. And sometimes we start to have a lot of problems on how really to manage these patients. So this is some of the data that we've learned that is one of the options in non-surgical candidates, and we still don't know exactly what are the best of these lesions to treat, whether we should only treat mucinous cystadenoma, if we should only treat, or if we can treat branch-type IPMN. This is in a clear debate. But just to tell you, what are the summarizing of the data that we've published over the years, and we start to have nice number of patients already treated with fine needle injection therapies. The resolution rate can vary between 35 to 79%. The complication rate, we still need to have a little bit of improvement, because if it's between 3 to 10%, and this is mainly when we treat and we inject alcohol in branch-type IPMN, because there is the risk, of course, to have some alcohol into the main pancreatic duct, and this can induce pancreatitis and some other complications, and mainly because if you take this part of the slide, we are really using high concentrations of ethanol. But of course, we can really start to ablate some of these lesions, and we can skip very complex surgeries in some of the patients with advanced cystic pancreatic lesions. Just to give you an example on how, with the things that we can obtain, and this is some pictures from Bill Brugge. This is one of an old case of Bill Brugge when he started with the ethanol ablation, and you really can take a look at the lesion, and after the ethanol injection, the lesion decreased, also the level of CA also decreased inside of the lesion, and at the end of the follow-up, the lesion went down to 1 centimeter with still decreasing the levels of CA. So it seems that it can be an option to treat some of these cystic pancreatic lesions, but still, I think we still need to work, all of us together, to find out what are the real proper indications for ablation, EUS-guided, for cystic pancreatic lesions. Because the question is, okay, it seems that it works in the beginning, but in the long term, you can really be able to ablate the tumor and have no recurrence of it. And this is a very nice study that was published very recently in Endoscopy for trying to evaluate the long-term outcome after the injection of ethanol. In this case, they included paclitaxel, so it's a combination of alcohol with a chemo agent, which seems to work a little bit better than just by providing alcohol. And just take a look. Still 10% of adverse events, which is just to take into account, but they obtained a complete resolution in 72% of the cases. But I think it's even more important, only 2 out of these 114 cases really presented a cystic recurrence. So it's only 1.7 of recurrence after a theoretically complete resolution after the injection of ethanol and paclitaxel. So again, this is an option that in selected patients we can really offer the possibility of provide a local therapy without the need of a pancreatectomy, or which we all know, and we have a surgeon here, which is not an easy surgery. But it's not only FNI, we start to have the first results, and this is a study that is conducted by the French multi-center group, and I got these results from Marc Bartet. So it's the option to perform radiofrequency ablation in cystic pancreatic lesions. So they have already included 14 cases in the subgroup of patients with cystic pancreatic lesions for RFA, and you can see that at 6 months, complete response rate was as high as 53%, and after 1 year, this complete response maintaining 64%. So it's, again, is quite nice numbers that at least giving the message that we might have in the future an option, an additional option to try to treat these kind of cystic pancreatic tumors. Again, we still need to work on find out what are the real type of tumors that are suitable and fit for this specific indication for EUS-guided therapy. But of course, I think that the biggest disease when we're speaking about pancreatic diseases and pancreatic masses is the pancreatic adenocarcinoma. And there has been some trials over the last years trying different chemo agents, trying to optimize the outcome on the management of this terrible disease. We got the data from Paolo yesterday about the survival rate at 5-year survival rate, which is almost ridiculous. So what we've learned, and there is a lot of studies that are starting in 2000 and they finish in 2016. So we've just tried several ablation therapies, cytoimplants, giving gemcitabine, Onyx 015, tenofovir, which is the adenovector radio-induced. But if you see, except of this study from Herman, there is more case series than really well designed prospective studies trying to evaluate whether this is useful or not. Another point, if you take a look at the staging, we're just trying to treat very advanced pancreatic adenocarcinoma. And my main complaint for EUS-guided treatment, FNI, for fine needle injection, when we're facing pancreatic adenocarcinoma, is look at the rate of complications that we get when we're trying to treat this advanced pancreatic cancer. I think we cannot really work with these big numbers of complications. If you take a look, in all of the cases, 10% sepsis, 10% duodenal perforation, 12% bleeding, deep vein thrombosis, GI toxicities, hematological toxicities. I think we cannot deal with this huge number of complications. So I think we still need to work a lot. There is some data that we start to have about the role, the potential role, because we can get the needle there, we can take cells out to diagnose, but we can also inject some agents, but we still need to work on what agents to provide, because these complications together with this poor response, I think, is not enough to feel that this is today an option to provide to our patients. At least from my point of view, I think we are still far to have what we need to provide to the pancreatic cancer. Because, of course, we can find this case, this is a slide provided from the group that tested the tenofovir, but I think this is the only case with a complete response. So, but there's almost 300 cases, and this is the nice picture, but if we just take a look at the other 299 patients, there was not response or just partial response. So it's not enough, I think, to go on to treat pancreatic cancer with these agents that we have available today. The other option is to give radiofrequency ablation, but just take a look at the numbers. In the US, 3 cases, 2016, 6 cases. So I think it is not enough evidence. We have not treated enough cases. This is more feasibility studies than real studies trying to evaluate whether this is useful or not. And I think with RFA, we still have complications, so we need to work a little bit more on what are the indications and when we can really offer this kind of therapy to our patients with a pancreatic cancer. Another of the treatment is cryoablation. This is the study that Paolo conducted in 2012. I can tell you that this needle is a little of a nightmare. It's a 14-gauge needle to cool the lesion, so it's quite complex to use. In the feasibility study from Paolo Arcidiacono, he succeeded in putting the needle in the tumor in the 70% of the cases, and this is how the needle looks like in the tumor, and this is the effect we obtain, and this is in an animal model. And we now, Paolo, give me this slide to show you what are the very first results from a multi-center trial. They have already included 15 patients, 5 with a borderline resectable pancreatic cancer, 10 with a locally advanced, And according to the RECIST criteria to evaluate response, we know that they obtain a stable disease in a nice number of cases at 4 months, maintain at the 6 months, but look, they obtain a stable disease, partial response, and progression, but there was not really a big response. They were only just able to obtain a stable disease that at least is trying to put a pancreatic cancer and as a chronic disease more than trying really to make a curable disease. But at this, again, this is another option, another opportunity that we can provide our patients with a locally advanced or borderline pancreatic cancer. And this is the idea, to downstage, trying to recover patients for surgery. So we're still waiting for the final results of this study to know whether this is a good option or not in this type of patients. But to try to give you some more better information, we have phase 1 clinical trials about new intratumoral injection agents that we try to provide in these advanced pancreatic cancer cases to try to improve the outcome. So this is phase 1 clinical trials. It's quite complex to understand for an endosonographer like me what is the meaning of this type of agents that they are providing and the results. But at least there is a lot of cases with a stable disease. So maybe there's a lot of people now working on trying to obtain what agents to provide to pancreatic cancer patients to try to improve the outcome. This is one of the trials with HF10 for unresectable locally advanced pancreatic cancer. And this is another phase 1/2 trial using immunotherapy with intratumoral injection of tholiendronate pulsed dendritic cells. And again, we start to have some data that they are able to increase the overall survival and the progression-free survival in the group of patients treated with this EUS-guided fine needle injection of this type of agent. So there is a lot of work ongoing. So the data that we have until now are not the best, but probably we will have a further improvement in the outcome with these new guided therapies, EUS-guided, for pancreatic cancer. The other group of pancreatic tumors, and it seems for all of us that neuroendocrine pancreatic tumors, there is a lot of data because there are some papers published, but if you take a look at the data, the published studies are with one case. So if you take all of the cases together, hardly reaches 20 cases treated, published in the literature, with fine needle injection of alcohol to treat neuroendocrine pancreatic tumors. And again, if you take a look at the complications, there is still one patient, one complication, one patient, one complication, one patient, one complication. So we still need to improve how to manage and how to treat neuroendocrine tumors with the injection of alcohol. What happens if we do RFA? Again, we have in the literature 1, 2, 3, 4, 7 patients treated, no complications. Thanks to God, this is the first series of cases with no complications when we treat locally with RFA, and probably there is a nice outcome with almost a complete response, and no recurrence after a long period. So probably one of the ideas and one of the good options for the treatment of small neuroendocrine pancreatic tumors is to provide RFA, not to inject alcohol. Again, this is the trial from the French group conducted by Marc Bartet, and this is an example of a small tumor that is be treated with RFA. There is 14 patients included, and very nice data. The tumor disappeared in 64% of the cases at 6 months, and significant response in 71% of the cases, which is not bad numbers, and this is probably a good information about a new option to treat these small solid pancreatic neuroendocrine tumors, that the other option is to go to a pancreatectomy. So probably in according to what indications, that might be an option to avoid, for instance, a Whipple procedure. But this is just some brainstorming that I'm giving to you about what is, I think it can be a good option for the future. But of course, not everything is pancreatic cancer, pancreatic tumors. There is a lot of data about the role of guiding the treatment of gastric varices, whether by the injection of glue together with the injection of coil. So this is considered today as a very good alternative for the treatment of these bleeding varices in the gastric varices. And there's a lot of data, mainly coming from some Spanish groups, about the role of this technique as an additional method to treat these bleeding varices. Is not so easy. Sometimes when you see these huge varices in the gastric wall, in the fundus, and you're just thinking to stick a 19-gauge needle, you're a little bit afraid. And then when you do it, really nothing really happens because, of course, you're going to put glue and you're going to put the coils. But you can be a little bit afraid. And it really works. And it's really a very good option as a rescue option. And in some centers, they start to be a first-line option for the treatment of gastric varices. And some more data, and this is data that I obtained from one of my friends in Spain, from Joan Gornals. In his unit, they start to provide alcohol therapy in some of these big gastric stromal tumors. And at least this is just a very pilot study that they presented. By injecting alcohol, they just have one more than a mild hepatitis, which is a slight elevation of liver enzymes, with no clinical relevance, and they were able to reduce the size of the tumor in a 40%. That these patients then afterwards went for a more conservative laparoscopic resection of these stromal tumors. So this is another insight that we can think about working in the treatment of this kind of lesions. I think all of the endosonographers, and we do not love to perform very much EUS in subepithelial lesions, although except if they are very big that we can FNI and do something, but not for the small ones. But you have a big lesion, and if you discuss with your surgeon and there is a little bit of a need for decreased size to optimize surgery, this might be in the future another of the options to work on. And just to give you some take-home messages, because I think at the end this is quite philosophic because there is not so much evidence. I think EUS-guided tumor therapy is just, in my opinion, in the very beginning, not celiac plexus neurolysis, but the rest of the techniques for really treating tumors. I think we are just in the very beginning. The key is that we can access tumors, but we still need to know exactly what should we deliver. I mean, we can stick whatever system inside of these tumors, but we still need to work on what to provide to the lesions. Probably nowadays the main indication might be pancreatic tumors because it's the things that we are most experienced. But I think we still have a lot to do. And I think we all should keep working because we need evidence. And I would like to finish with these words from Desmond Tutu, which is a very well-known guy working for peace in the world, that hope is being able to see that there is a light despite all of the darkness. And since I've been speaking a lot about pancreatic cancer, and I think there is a lot of darkness in pancreatic cancer, and I think we still need to find some light for these kind of tumors. That's, I think, we all should to work in the future to know whether we can improve the outcome of all of our patients by going for EUS-guided therapy. And thank you very much for your attention.